So we'll give us 2 more minutes. I see we have a nice quorum online. We might not get many people in person today, just because of the rain and traffic. But we'll go through it. Okay. I think we might get started. For those who don't know me, my name is Charlie. I am one of the third-year fellows here, and this is my last grad rounds. This is my farewell tour. So with that being said, I wanted to give a lecture that was really about my journey through residency and fellowship and talking about the contributions that I've made to the field. And when I was putting pen to paper, I really came across these 3 bullet points for what I want to talk about today, which is the who do we treat, the why do we treat, and the how do we treat. But as I put it together, I realized I'm just missing the what and the when. And I made it a point to talk about that. So we are talking about the 5 W's in lymphoma. We're talking about representation in clinical trials and whether we're living longer and feeling better, which are the real reasons why we treat. And as I introduce those topics, we're going to also explore some of the correlative studies that we're doing here at Brown to actually add on to our current treatment strategies and figure out how to best treat in the immunotherapy era. Because the classic dogma of dose-limited toxicity doesn't so much apply when you're actually engaging T cells and your effector cells are not limited by the same pharmacokinetics and pharmacodynamics that traditional cancer-directed therapy has been. So I wanted to start with the who do we treat and why before we dig into the rest. But with that being said, I wanted to start with the thank yous, and I'll end with the thank yous also. A big thank you to my mentors, Dr. Sloan from residency at BMC, who really taught me about equity. Adam Olszewski, who really helped me take charge on some correlative studies from his investigator-initiated trial, and I owe him a great deal of that. Then there are Ari Pelkovitz, who gave me the space to really bounce a lot of ideas off of him and really mentored me through evidence-based critical appraisal. All 3 of them will feature prominently, and you'll see them in the bottom right where I put a little face with an example on this slide. But we will put their face next to the studies that we've done to attribute credit. Dr. Olila, on the end, you will not see his face in the example bubbles, because even though he mentored me through many projects, none of these have come to the finality in time for this talk. So I put perseverance in an asterisk right there. He has taught me perseverance. He also taught me able to bow out of projects. And the nature of academia is you're going to start more projects than you finish. So Dr. Olila, even though our work is not featured, thank you very much. So with that being said, I am leaving. This is my last grand rounds. I am moving just north, 1 hour up the road to AstraZeneca, where I will be a medical director for clinical development. So a lot of this talk will be focused on drug development, and that is what my job will be come July. I did ask ChatGPT to age myself. Moving is stressful. I hope I don't age that much over the course of the next month or 2. At first, I asked it to make me look old, and then I had to peel back and say, "Whoa, make me less old, please." This is a nice little. All right. For the table of contents for this talk, I am adapting Maslow's hierarchy of needs. So this is Charlie's hierarchy of needs. We're going to start with the very bottom, which is who are we treating? Without having the right patient population for a study, the rest doesn't matter as much. The middle 2 are going to be the 2 core tenets of why we're treating patients, which is to live longer and feel better. And then at the top, we're going to explore how we're treating patients right now, and then our investigations into both time-targeted strategies, which will fall under the when, and what will be about the molecular targeted strategies that we could explore. Self-actualization is still at the very top. I got to give you a spoiler for the very end of this talk. I do not reach self-actualization. Still striving for that. All right, so chapter 1, who are we treating? I wanted to start this with this article. I think that we're all probably shaped by some really pivotal articles that we read early in training, and this was one of them. This is from the Common Sense Oncology group. Some of the big names that you'll recognize in this list are Vishal Bawali and Christopher Booth, whose names you will see pop up many times in this talk. But the Common Sense Oncology group really talks about equity, which is who are you studying? But the two questions that everyone should ask are, will the treatments make me live longer? And will I feel better? So I'm going to start with the question that patients shouldn't have to ask, which is, did they even study me? And my first exposure to this was in residency, Boston Medical Center. Got a gentleman coming in with multiple myeloma, and he's on lenalidomide maintenance. And he presents with these hand changes. The palms of his hands were getting darker and darker and darker. It happened early in treatment. It was distressing. It was irreversible. And he said, why is this happening? He had asked many doctors before this, but I was lucky enough to be in the room with Dr. Sloan, who said, this happens in patients with dark skin who are treated with lenalidomide. We see this, and it's not well described in the literature. And in that moment, we did what I think good clinical investigators should do in recognizing that this was underappreciated and not well described. We went ahead and we started to describe it. And we started by looking at all the clinical trials of lenalidomide. And that first trial that's listed with 1,076 participants, that was the trial that led to the registration of lenalidomide with the FDA. It had 1,076 participants, but only 15 were Black. So the only trials that actually had adequate representation of Black participants were government and academic sponsored trials. Even then, they did not meet the level of Black representation in myeloma. In the US, about 15% of the population is Black, but Black patients are more disproportionate to getting myeloma, and our myeloma population is about 20%. When we looked at all of the skin changes in these trials, there were only 3 absolute events of hyperpigmentation, which was 0.06%. This was not aligning with our clinical experience, so we took it to the next step and we polled our patients. And what we found was that hyperpigmentation was reported about 40% of our Black patients, 40%. And that is a huge discordance between the reported literature and our lived experience. And then you have to ask yourself, why is this happening? And I think most likely, the reason is the registering trial that had such little Black representation led to an underappreciation by the medical community that this adverse event could even exist. And with that being said, when you don't know what to look for, you'll often ascribe the reason to the wrong thing. So I included here some nice little shout outs that we got along the way after we distributed this paper. On the left, you'll see this was a text message actually from my co-resident at 4:30 a.m. So he was very clearly on the night shift, but he had a patient on len maintenance come in with darkening of his palms, and he said he was literally about to work up adrenal insufficiency, and then he came across Calvin quickly. On Twitter, we got a nice little shout out from Dr. Levitz, who was a myeloma doc in New York, and that his patient came in with skin darkening. And this is the first time when you look at these 2 papers in parallel, where we describe first the industry representation, and then we described our hyperpigmentation rates of EMC. If you put those together, you really start to describe a story. On the right is a little screenshot from Dava Whistler this year. Just behind this man's head, you can see Rod C. what's covering him is my full name, but this is our data. But that's where we talk about representation. And I think that the first step in fixing this problem is talking about it. And it's good, people are talking about it. I was hoping that here we are 4 years later, we start to see some of the fruits of our labor, but clinical trials take a long time to recruit. So the Aquila trial, which looked at daratumumab in high-risk smoldering myeloma, acknowledges that smoldering myeloma is more common in Black patients than any other group. But the proportion of Black patients enrolled in this study was low at 2.8%. So if you're looking at this from the optimistic point of view, this is double the representation that they had in the original lenalidomide trial. But the realistic view is that this is much less than what it should be. It takes time to enroll these trials. Enrollment for this trial started before our description of hyperpigmentation. But this deserves a real talking point. And you can see in the bottom, page 26, if this was on page 26 of the paper, you would say that's buried pretty deep. This is actually page 26 of the supplement. So I think that we should be talking about this one. Even though I talk about fruits of labor taking time, this was a little unexpected build on our original research. This is from a dermatology journal, and they say that recently lenalidomide was observed to cause darkening of the skin in Black patients who are experiencing myeloma. And they went ahead and did an in vitro cell experiment, and they're looking for treatments for vitiligo. And they actually found that lenalidomide actually recruits melanocyte stem cells to the area that you're actually using it, and it creates expansion of those stem cells as well. So this was a little bit of an unexpected benefit from our study. First, it's nice to have a mechanism to explain what we're seeing, but to have a treatment for a disease that is especially bothersome for many people is very exciting. I would counter, I have some pause about using lenalidomide for vitiligo, especially given its cost right now, and its risk of secondary malignancy. Okay, chapter 1. This was who we are treating, and I want to keep this in the back of our mind as we explore some of our other trials. If you're not looking at the right patient population, the rest of these questions that we're asking will be memory. So we're going to start with the next question, which is, will people live longer with our therapies? And I'll call common sense oncology with common sense questions. So for this, we're pivoting. We went from a lymphoid malignancy in myeloma to lymphoid malignancy in follicular lymphoma. You can think about some of the similarities that they have here. These are diseases that have a prolonged disease course. For follicular lymphoma, median overall survival is about 15 years in the current therapeutic area. For myeloma, overall survival was about 90% over 4 years in the Perseus study, where they added daratumumab to the front line. So they're both experiencing overall favorable survival prognostics, but even then, these cancers are still associated with excess mortality. So this was a study from just a couple of years ago. It looked at age-matched controls, and even low-grade lymphoma has an absolute increase in death of 14% over 10 years. And if you are less than 60, you are just as likely to die from your lymphoma as other causes. If you're more than 70, it starts to be about 1/3 die directly from lymphoma, 2/3 die from other causes. But we have to keep in mind that lymphoma and its precursor conditions like CHIP are associated with increased rates of cardiovascular events, liver disease, and we're probably underappreciating a lot of the other adverse events that are associated with. Now, the question of would we live longer is important because the accepted surrogate endpoints for approval for drugs in the follicular lymphoma space is complete response rate, overall response rate, and progression-free survival. Progression-free survival is the most common surrogate endpoint used for registration. But when you have a patient sitting in front of you asking, am I going to live longer with this drug? They are asking about overall survival. They are not asking you, how long will it be until I reach the next therapy needed? So this is a gap. So we explored this. We looked at a surrogate endpoint validation on the trials level, which is the right way to do a surrogate endpoint validation. If you are doing a patient level surrogate endpoint validation, it's not really a surrogate endpoint. This is prognostics. The surrogate is at a trial level. So we looked at 22 arms with over 10,000 participants. We found that progression-free survival was weakly associated with overall survival. When your coefficient of determination is less than 0.3, that's a weak association. I think a good way to visualize this is to recognize that the coefficient of determination, which is the R squared, is also called the variance. And when you only have 15% of overall survival variance, that means you're leaving 85% of the overall survival changes on the table. So progression-free survival is not a strong surrogate for overall survival. And you have to ask yourself, are our trials actually measuring the important question? Will we live longer? No, we are going to see surrogate endpoints become a much bigger part of the conversation. Vinay Prasad, who on the left talked about how our surrogate endpoint validation was a very strong validation. He said it in the same sentence criticizing minimal residual disease, which is now an accepted surrogate for accelerated approval in the multiple myeloma space. Vinay Prasad is a very strict data textualist, and he really built a big platform, especially on COVID policy, where he was very critical of Weinstein in the absence of positive data. He is now promoted to the director of CBER, which works on the approval and registration of biologics, including vaccines. I would add, I'm a little wary of his responsibility for vaccines because he used this platform to very strongly advocate for evidence-based COVID strategies. He has not used this platform to debunk any of RFK Jr.'s anti-vaccine policies. And you would hope that he would use this very strong fund of scientific knowledge for good. And I hope he does. But I think. Oh, and for anyone who hasn't read *Malignant*, this is from his 3 controversial days, where he talks about surrogate endpoints and right patient populations. And I highly recommend it for every chemo fellow. I think it provides a really nice context to frame all the trials that we've been exposed to. All right, these are the papers that have built upon our work so far. They really come in 2 flavors. There's cost effect analyses and there's surrogate endpoint validations. So on the left, we have cost effect analysis of mosunetuzumab in the relapse setting in the United States and in Italy. What gets especially complicated with cost effect analysis is that you are looking for a quality adjusted flight year that is less than $150,000 per year, which has been signed by a government group. The tricky part is that progression-free survival, that can correspond to a quality adjusted flight year. But if you're not improving death, if you're not improving mortality, overall survival, that weighs heavily to these cost effects analysis. And then on the right, we have endpoint surrogacy for CLL. We have a review of surrogate endpoints in mature B-cell neoplasm. And the common thread through both of those is that CLL and lymphomas progression-free survival does not predict overall survival. And you have to ask yourself, is progression-free survival in itself a worthy endpoint? We are doing this again. I think the most important times to ask yourself about whether or not an endpoint is valid for overall survival is it depends on the disease and it depends on the treatment that you have. So if you have a disease that has very morbid progression events, those are dangerous. And when you prevent progression events, that tends to improve overall survival. But you also have to ask yourself about post-progression therapies. So for follicular lymphoma, we looked back over the past 20 years where we had the chemoimmunotherapy era with rituximab plus chemotherapies. That largely has not changed. But when you have diffuse large B-cell lymphoma, the paradigm has changed dramatically. The introduction of CAR-T, which was approved in 2017. So as our post-progression therapies for diffuse large B-cell lymphoma improve, we have to reassess whether progression-free survival is as valid of a surrogate. What we found is since over 2017, there were only 4 trials in this space. We did not expect a very robust association, but we actually found it. The overall survival variance is 98%. So compared to follicular lymphoma, where you were leaving 85% of overall survival on the table, here you're only leaving 2%. It's actually a very valid surrogate. But I think the big takeaway here is that there's only been 4 trials in the relapsed DLBCL space since 2017. And this might be an area of actually unmet need. Okay. I wanted to make this pivot here because we had mentioned, will people live longer? And we use that as an introduction into cost effects analysis. We introduced quality adjusted life years. Problem is, quality is not measured by absence of disease, especially in the era of indefinite therapies that bring their own adverse effects. So this question, will people feel better? Common sense question in patients should be asking you. So we looked for this. We looked at 103 trials of indolent lymphomas. We found that only 53 trials were collecting quality of life endpoints. And what I think might be even more surprising is that only half of those trials actually reported those endpoints. And that could be a publication bias where the quality of life results are negative. They're actually not reporting that data, which is harmful for shared decision making with patients and providers. But among those that reported endpoints, there is a strong association between progression-free survival and overall survival with quality of life. But if you look at these graphs, it's not universal. There are plenty of trials that cause an overall survival benefit, but actually worse quality of life. And when you have that discordance, that really merits more of a shared decision-making conversation because you will be telling a patient you will live longer, but you will feel worse. When we have that kind of conversation, I think it's important for us to interpret the data ourselves, because when we looked at these papers, we also looked at the framing. We took the objective data from the results section, and we compared it to the subjective language in the conclusion. For a quality of life paper, the goal is to improve quality of life. If you are not improving quality of life, that data does not support its use. And I think that's important because when you look at the discordance and how these are actually reported, you can look at the CLL4 trial where it showed that quality of life was actually worse. And in the framing section, in the conclusion said that this data actually supports its use. And this was in a dedicated quality of life paper. This is in the absence of survival data. It's really not truthful to communicate these kind of results to patients in the conclusion section with a favorable frame for negative results. It also feels less truthful when you have a neutral quality of life and you say that supports its use, because the goal of treating cancer is not to maintain your quality of life, it's to make people feel better. That's in our paper. So for those, no, I'm so glad you just said this. For those who haven't read the paper, and I have the PubMed ID at the bottom, if you're able to screenshot, you can try it now, but otherwise I'll send a paper to everyone.
Yes, please.
There is not a single universal quality of life scale. Some scales were used more than others, but moving forward, we propose a more universal system of reporting quality of life. We propose a more objective way of framing this results to providers and to patients. And we propose a more universal collection of quality of life endpoints. Because if you're not even collecting quality of life endpoints, how do you actually comment on if people are feeling better? The first step is people talking about this, and thankfully we are. So this was only back in April, but the Alliance spring meeting in lymphoma happened April 30th and the 2nd, and this featured prominently in their plenary talks. So thank you, Adam, and thank you, Jess, for sending these pictures. I was not there in person, but the data was. So I'm really pleased to see the Alliance Cooperative Group talking about this. And using the same data set, we have a little spin-off project where we are looking at quality of life reporting rates between cooperative groups versus industry and government-sponsored trials. I suspect that cooperative groups could be the way in reporting quality of life in a way that industry is not motivated to do so. Okay. So we talked about who we're treating and why we're treating. So we need to ask, are patients being studied? Are they living longer? Are they feeling better? And now we get to ask, can we treat smarter? These are the hows. So we're going to talk about T-cell exhaustion. We are going to talk about a correlative of Adams throughout 401 trial, where we are using a CD20 by CD3 bispecific antibody. Bispecific antibodies are different than chemotherapy. When you are engaging the CD3 positive T cell, your rate limiting step is no longer dose, it is your T cell activation. So we're going to talk about what we found in the study. I'm going to talk about really the uncertainty in saying that this data is not complete yet. But with the prospect of me leaving, I also want to introduce some of the next steps that we would take if the data did turn out to be. So I wanted to introduce one of the seminal papers that influenced me in my thinking during fellowship, and it was about blinatumomab and ALL. This was the original bispecific antibody. This is back when they were called BiTEs, so a bispecific T cell engager instead of bispecific antibody. It's given under a 28-day continuous infusion, which is different than what we will be talking about during this talk. But what they found was that over the 28 days, what you start with is activation. Now, there are markers of activation that we see here. Markers of activation include these activated cytokines and T cell proliferation. But to truly say if you're T cell activation or exhaustion, you need to do an actual cytotoxic experiment. And they did this. They found that cytotoxicity increased in those first 7 days, followed by a decrease in toxicity below the baseline levels from days 7 to 12. I wanted to point out here that PD1, TIM3, and LAG3 were all increased as compared to baseline from days 7 through 28, which was one of the first times that I really started to think about PD1 and LAG3 as dynamic markers, because where we use them now, PD1 we use across many different cancer subtypes. LAG3 targeted therapies we now use in melanoma, but we tend to look at the PD1 levels at time of diagnosis, and we don't so much consider how they dynamically change over the course of therapy. So when I started to talk earlier, I had introduced time-targeted therapy. I want us to keep that in the back of our minds, where right now we really treat the addition of immunotherapy as a static decision, where we start in the beginning and we don't peel it off. But these levels change over time. And maybe the addition of the immune therapy agents at different times, the introduction, and also the cessation, the treatment-free intervals, could ultimately impact patient health. So they did a 3-arm experiment where they did the classic 28-day continuous test. They added dasatinib to the continuous therapy, and then their third arm was adding treatment-free intervals. And what they found was that mean-specific lysis was higher in the treatment-free interval group and the dasatinib group, and exhaustion markers were lower in those groups as well. I wanted to focus on the treatment-free interval group, and this is the graphic representation of that treatment-free interval group. Ultimately, over the 28 days, when you think about rather a dose-limiting toxicity, but you think about the effect limiting T cell activation, we're actually getting more T cell activation by incorporating less drug strategically. And my mind was blown. My mind was blown. The idea that we could incorporate treatment-free intervals to actually increase the efficacy of the drugs that we're giving blew me away. And I started to think about some of the most pivotal trials in oncology. And I think maybe the most pivotal trial is a de-escalation study. If you've ever treated myeloma and you think about BRD and how the D is a little d, it wasn't always this way. It used to be a big D up until 2010, when it turns out that big D was causing death. High doses of dexamethasone cause more death without progression of disease than lower dose dexamethasone. So up top, you see overall survival. The green line is actually the lower dexamethasone group. The blue line is high dexamethasone group, which was the standard of care at the time. When you look at the bottom, that's the progression-free survival. And you see that the lower dose of dexamethasone actually caused somehow better progression-free survival. It could have been very much in the same spirit as bispecifics causing T cell exhaustion. But on the right-hand side, when you see those bottom lines, the red is death without progressive disease from the high dose dexamethasone group. That is really naming that is death from treatment without death from treatment. This was the amount of people that we were killing from dexamethasone specific toxicities rather than myeloma. So back to my mind being blown, I am thinking about bispecific antibodies. I'm thinking about the infections that we're seeing. I'm thinking that treatment-free intervals will not only increase our T cell activation and maybe increase our cancer cytotoxicity, but it is also decreasing the T cell exhaustion. Maybe we will see less infections. Maybe we will see less side effects. But the big question was, does this happen with intermittently dosed mosunetuzumab? At the time, there was nothing. There was no answer. We were starting this exploration really at the forefront of this field. So, enter brew up 401. Dr. Olszewski has joined us. This is his study very much. On the left, we have a schema of the trial. It starts with mosunetuzumab monotherapy, and this follows with a mid-treatment PET after cycle 4. And then you either augment with lenalidomide if you have anything less than a complete response. But if you're in a CR, you continue with mosunetuzumab monotherapy. This is similar to the treatment algorithms that we used to see in Hodgkin lymphoma, where we do a PET to get a PET after cycle 2. What you see on the right is our clinical responses, which will go further in detail later on. But the big takeaway here is that we have accrued quite a few amount of people. Many have reached the end of treatment, which gives us the opportunity to look at their T cell dynamics and cytokines over time. So, like good clinical investigators, we sought the funding to actually quantify this, and that takes money. And we got it through the Young Investigator Award. I texted Adam. We got the Young Investigator Award, and Adam said, "Holy poop!" Yes, holy poop. And thank you, Howard and Ruan and Matt for being in the audience for the reception. Adam invokes, this might be the first ASCO YIA in the history of Rhode Island Hospital. And I can say it is. We have on the right institutional disparities with ASCO grants. For the YIA, 38% of ASCO grants come from just 4 institutions. And I highlighted on the left-hand graph, the states represented go straight from Oregon, Pennsylvania, South Carolina. They don't even mention little old Rhode Island, but now they will. It's cool. Our hypothesis was that since mosunetuzumab is not continuously dosed, we would see this T cell activation for a longer period of time, but T cell exhaustion would happen in the later cycles. This was our poster at ASH 2024. There's a lot of nuance here, and I'll go through some of the nuance in the updated ASCO 2025 poster. But I wanted to draw the eye to the conclusion section, and I put a little visual abstract of what was my interpretation at the time, which was we see this activation peak around cycle 2. We see exhaustion markers start to take over around cycle 5, and then normalization around cycle 8 But I am trying to get away from that simplification of T cell activation and exhaustion. So as a medical community, we used to really say T cell activation, T cell exhaustion. I am trying to say markers of activation and inhibition instead. When you have markers of inhibition, I'm starting to think of those as breaks apart. So as you move from a naive T cell to a memory T cell, you often start to express those kind of inhibitory markers. So that's like a car going 60 miles per hour and accelerating, putting on the brakes and starting to coast at around 60 miles per hour or so. It's hard to say if your car is moving at 20 miles per hour or 40 miles per hour, just based on the inhibitory markers. The real test for that is going to be a cell culture and experiment. So with that being said, this is the new, more nuanced visual abstract. For those in the room, the colors are not so bright on the TV, but on the computer, they're a little bit more bright. But we see markers of activation and inhibition happening at the same time. We have markers of T cell activation actually peaking as early as cycle 1, day 8, whereas we have a T cell exhaustion markers starting to peak around cycle 5. I wanted to draw your attention to this visual abstract, so that way we can review the ASCO poster that is coming up. It's Sunday morning. Please visit. We love visitors. It's at the same time as our survey endpoint validation poster, so you can do double duty. You can visit us, see both of our posters. What we have here are the clinical outcomes from the BRUAC 401 poster. What you can see is that we enrolled 40 patients. 34 have been evaluated for end of treatment response. Most end up with an end of treatment complete response. So associations with complete response are trickier to tease out, but there's a good variety of people who had mid-treatment CR and anything else. That's important because people who had less than a CR get lenalidomide augmentation. So our later studies can explore the different T cell dynamics that you see when you add lenalidomide, which might mirror the different T cell dynamics that you see when you add dasatinib or lenalidomide. But we are going to look at associations with mid-treatment CR based on cytokines and T cell subsets. So these are the changes on therapy. We have a dot plot here with our activating cytokines up top, and you can see the larger the bubble, the more statistically significant it is. You can see that these changes happen as early as cycle 1, day 8, and cycle 2. And by the time we get to cycle 5 and end of treatment, they have normalized. What you have many on the bottom, like PD1, SIM3, LAG3, CTLA4, those start to become increasingly significant around cycle 2. They stay significant at cycle 5. By cycle 8, they're back to normalization. What you also see is over time that you actually go from a naive T cell to an effector memory subset over the course of treatment. And that's preceded by these activating cytokines. So this is likely the feedback loop where we start with activating cytokines, and that actually ends up differentiating naive T cells to effector memory cells, which is really driving a lot of the cytotoxicity. When we talked previously about dasatinib actually increasing cytotoxicity in the blinatumomab trial, that has also been done in CAR T. Those CAR T trials were accompanied with some correlative studies, and it found that adding dasatinib also caused naive T cells to differentiate into memory T cells and restore cytotoxicity. Now, this is a real surprise. This is not what I had intended to study when we started, but this is a dot plot with association with response. These are all the cytokines that we looked at for mid-treatment complete response. CTLA4, you can see, is the only ones that have response. Those are the only cytokines that are significantly associated with the mid-treatment response. But you'll see CTLA4 at cycle 1, day 8 is associated with our mid-treatment PET at the end of cycle 4. I think that is amazing because at lower, yes. CTLA4 is an inhibitory cytokine, so you expect lower levels of CTLA4 to be associated with higher rates of CR. At cycle 1, day 8, these patients have not even received their full dose of mosunetuzumab. We are still stepping up that dose to have a predictive biomarker at cycle 1, day 8, opens the door for a whole different paradigm of mid-treatment complete response assessments, which we can talk more about later. I would also add, what was interesting is that we see higher pre-treatment natural killer cell abundance and associated with a mid-treatment CR. And when you accompany that on the left-hand side with these natural killer cells over time, you see that our natural killer cells are increasing over time. That could also be because of these activating cytokines that we have very much elevated in the beginning of treatment. I want to plant some seeds for our allo-NK therapy. One of the main limiting barriers to incorporating allo-NK cells into cancer therapy algorithms is that allo-NK cells don't tend to persist for very long. They tend to persist for around 7 to 10 days. There is currently a trial at Dana-Farber looking at adding an activated interleukin, I think maybe IL-2, to allo-NK cells to increase the amount of time of persistence. But perhaps future therapies might explore adding bispecifics, which will not directly increase cytokines, but indirectly could increase the persistence of allo-NK cells. All right, so going back, this is the visual abstract again. And I wanted to highlight these two findings right here because I want to emphasize I am leaving that the opportunity to build upon this in an academic setting has passed, but I would love for someone to take the torch. I wanted to start by highlighting the idea that decreased CTLA-4 was associated with a mid-treatment complete response. So at the top of this slide, this is the current schema for Burrell 401 featuring a classic mid-treatment PET at the end of cycle 4. And these are really the two clinical scenarios that I envision, where if you respond well to mosunetuzumab monotherapy, you are approaching CR quickly and you're essentially approaching it by cycle 5. If you have anything less, your disease is not completely controlled for most of your treatment. If we start to incorporate a biomarker adapted approach as early as cycle 1, day 8, you could intervene much earlier. I don't so much think of this as an opportunity within indolent lymphomas, since diagnosis and progression events tend to not be very morbid. But when you think about Hodgkin lymphoma, when you think about more aggressive lymphomas like the B-cell lymphoma, or maybe in the future even Burkitt lymphoma, if we had a predictor of early response, this could help us either emphasize de-escalation studies like the RAFL approach for Hodgkin, or it could help us predict people who will have a less than satisfactory clinical response and can actually up-regulate our intensity of treatment. So the opportunity, cycle 1, day 8 is very exciting. But I think more importantly, if you had biomarker testing instead of PET, PETs are expensive, PETs are radioactive, PETs are geographically limited. Biomarkers are less invasive, they are less expensive, and they're more accessible, especially in more rural areas where PET, especially is a big barrier. As we are incorporating more PSMA PETs, we are starting to find a tighter crunch on the PET schedule, and this would alleviate a lot of that systemic burden. Not ready for prime time, but I think it's a really exciting idea. All right, and then I want to briefly touch on this early increase in activation markers and this later increase in inhibitory markers. This next slide is also, it's a slide that's not ready for prime time. But I wanted to start to introduce this idea that we now have some answers. So I put activation with a star, I put exhaustion with a star. But with our treatment of intermittent mosunetuzumab, we see that between cycles 1 and 2, we get our activation markers. By the time we get to cycle 5, it was really normal. I think there's a few different ways that we could approach, maybe incorporating treatment-free intervals into this regimen. And it could look like this. It could also look like giving the same amount of mosunetuzumab over a longer period of time. But I think that this really has a lot of potential. If you incorporate treatment intervals, you are improving time toxicity, where your patients are in clinic and much less. You're improving financial toxicity. There is less drug given, which is less expensive. And ideally, you are improving all of the markers of quality of life. When you have less treatment-related adverse events, people will live a better life. That comes with a big asterisk as well. There was a de-escalation study of venetoclax at ASH this year, which looked at 21 days on, 7 days off versus 14 on, 14 off. And it found that it was non-inferior, but actually the adverse events were exactly the same. So that's a big question. Ideally, this would increase your amount of time in T cell activation and improve the amount of cancer directed effect of them. And thinking about the opportunity for de-escalation studies, these are some of the most impactful studies that you can run in this. For the sake of completeness, I went into this really excited about this exhaustion strategy on the right. When I saw the original blinatumomab paper and I saw the increase in the inhibitory markers of PD1, 2, 3, LAG3, those were all very exciting to me because those are all actionable therapeutic targets. I really liked the idea of changing the way that we think about PD1, especially where we think about that as a baseline level predicting response. But PD1 is a dynamic biomarker. So perhaps incorporating PD1 when these markers are peaked, perhaps incorporating these targeted therapies when you actually had your treatment-free intervals off of bispecific as a different mechanism. I think it's all really exciting, not ready for prime time. And I'm looking forward to maybe the next 5 years, a fellow from here taking over the reins. All right. We talked about a lot. We talked about the who's, the whys, and the hows. I want to give a big thank you again, Dr. Sloan from BMC for teaching me about equity, Dr. Olszewski in the room teaching me about correlative studies, clinical trials, Dr. Pelkovitz teaching me about evidence-based critical appraisals, Dr. Lola about perseverance and also when to stop perseverance. With that being said, here I am on the bottom, an older version of me for 2 months from now. My traditional means of contact will have changed. My emails are at the bottom. Please reach out.
Is that AI generated?
Yeah.
You look like a guy that's
Thank you,
dating.
everybody. I really appreciate you.
I have a question. I'm glad to hear that there's another disease subspecialty that recognize how deadly dexamethasone is. We use a lot of dexamethasone, right? And I saw that paper, Lancet Oncology by Rajin Kumar. I'm very happy to see that because unfortunately in neuro-oncology we do not have proteasome inhibitor, we do not have bispecific antibody, we don't have a lot of the drugs that work, okay? And we are still sticking with a lot of it as an episode. And we also show that when our glioblastoma patients are on mesomethasone, they die soon.
Yeah. I think it's so important, and I think it's a really great opportunity, especially within academic medicine, because de-escalation studies don't require drugs given by a company who are giving standard of care or better. I think it's easier to recruit sometimes than actually escalation studies, and we should be doing more of them. Thank you. Jared.
Charlie, great talk. Thank you for giving us a tour of the work you've done over the past 3 years, and thank you for it. And wish you well. You look great as an old man.
Yeah. Oh, here's hoping. This is a very generous interpretation where I keep all of my hair. So.
Yeah. So you're in the experiment in the blue eye, you're measuring serum. Just we use an assay that measures a panel of
Yeah.
kinds of cytokines, and then you're doing flow cytometry on peripheral. Lymphocytes.
Yeah, it's all peripheral. There's
Yeah.
no tumor biopsies here, which I think increases the probability of this being incorporated into widespread practice. Because if you are requiring a mid-treatment response, adaptive therapy, that involves tumor biopsy, that's invasive and it requires procedural that's and it's hard to do. I think it's so exciting that we can do this off of peripheral blood. What is upcoming is we do have single cell RNA-seq upcoming with tactical weapons lab and it's with so that will contribute to our findings in the paper, which I'm hoping will be ready mid-time next year.
My question is, tell me about the heterogeneity of your patient population. Do they have a lot of disease? They have a little disease? Where's the disease? Does that matter? And then in visualizing what you're measuring in the peripheral blood, comparing to what's happening in the tumor as the cancer interacts with the immune system, is what you're measuring in the blood a reflection of what's happening in the tumor microenvironment, or could you be fooled because you're measuring something that's happening that has to do with an interaction with the host and not the tumor?
I think those are such good questions. I want to start by talking about the heterogeneity and then later talking about the T cell dynamics associated with that. So for follicular lymphoma and marginal zone lymphoma, we're doing a combined study. We often don't need to treat low tumor burden disease. So there's a swab study which is opening, which is comparing rituximab monotherapy versus mosunetuzumab, which is controversial in its own right, because there was a very good study which showed that watch and wait is non-inferior to rituximab for follicular lymphoma. But treating with rituximab does decrease anxiety associated with diagnosis. So the real pitch for this trial is that this is going to improve quality of life. So with that being said, all of our patients would have fulfilled requirements for treating. A lot of that's physician discretion, but the GELT criteria is what we often use for follicular lymphoma. So that's burden of disease, that's constitutional symptoms, weight loss, cytopenias. There were a couple of patients who did not respond favorably to mosunetuzumab, who had very different circulating cytokine levels. We're hoping to, gather some more patients and look to see if there is a difference in pretreatment cytokines and predictors of response. We did not see that pan out at a statistically significant level in our data set, but it could be because there were only, and Adam will correct me if I'm wrong, only 2 or 3 patients who did not respond favorably. But those looked very different than our other patients, and their disease behaved very different. Yeah.
Is this probably surveillance? Your next way, and next question is they address what trust. What you guys in your past how is this done? Because they have all the pieces for us. Mostly talks about them are different other problems.
Yeah.
How we're gonna
Boy,
stratify all of
it's such a good question. So for those who didn't hear, Ina was talking about post-treatment surveillance cytokines in our experiment. Our experiment really ends end of treatment with a few weeks post-treatment we're getting cytokines. I think it is a really exciting idea about biomarker-based surveillance instead of imaging. There was a recent paper in the New England Journal which showed that no randomized trials of imaging-based surveillance actually improve survival outcomes. But it is something that we do out of dogma for diffuse large B-cell lymphoma and aggressive lymphomas, where we get these serial cascades. There's a really good paper by Chason about the argument for less post-treatment PETs and less frequent surveillance PETs for indolent lymphoma. I think the future could be less invasive, more accurate surveillance of cytokines, and that could be a project really worth exploring.
Hey, Charlie, can you hear me?
Yes, hi, Art.
Hey, so first of all, amazing job. This was awesome to be a part of over the years, but to see it all displayed today, you've done a fantastic job with your research during fellowship. I was just going to comment to Jerry's question. We have another study looking at those same patients where we're trying to more directly investigate the tumor microenvironment with spatial transcriptomics. We have some pretty interesting data from that, and it's not a ton of samples. And as Charlie pointed out, most patients had complete responses, so it's hard to take too much from that to determine what's impacting response. But one of the things we're hoping to look at, especially if we're able to analyze more patients, is the correlation between what we're seeing in the tumor microenvironment and these peripheral studies.
I mean, the thing I'm worried about is the upregulation of immune checkpoints could be a healthy thing for the patient.
Yeah.
I mean, unless, so, and then if you go after that, you're actually, and we didn't actually hear what the toxicity of mosunetuzumab was. Or was there any?
Oh, yeah, the number one thing that we worry about with mosunetuzumab is risks of infections. And that's shared across bispecific antibodies, and that is a late toxicity as well. Like when we treat patients with teclistamab, which is a BCMA-directed bispecific antibody for myeloma, you have grade 3 and 4 adverse events of infection up to 2 years after you stop treatment. So this is a persistent problem. A lot of the problems that we see with mosunetuzumab is the therapeutic depletion of B cells. We are intentionally trying to deplete B cells. There was a paper from Rutgers, Matthew Matazar published this, where it could take up to 18 months to reconstitute your B cells. So you are especially vulnerable for those 18 months. But T cell exhaustion is described as a mechanism for resistance and relapse in indolent lymphomas. This is really the first study of looking at the dynamics here at time of diagnosis. So I think there's a lot left to explore in this space. But I share the same concerns. A lot of this antigen stimulation, especially for a long period of time, definitely leads to T cell exhaustion, which is bad for cancer. It's also bad for your immune system.
Also, one additional aspect that we're now recognizing is the T cell diversion, which happens like 3 weeks into the treatment, where all these T cells get bound to the monoclonal antibody, and they're out of the system, which you can actually count in the blood. And it's actually like 3 weeks or 4 weeks into treatment, we see weird things happening. In our trial, 2 totally healthy patients got PJV pneumonia. We sometimes see people throw out a zoster episodes a month into the treatment. You're probably going to start seeing this with whatever blah you have. That's 3 weeks into treatment, all these T cells are not doing their normal job because they're bound with something and looking for other trouble. That resolves like 2-3 months later, but now a lot of people actually need to go back trim for the first 2 months to avoid PJVs. That's like a new thing. I thought there one comment kind of typed into it, which shocked me with my conflict of interest here close. 2 days ago, ODAC 821 recommended against approval of glofitamab in combination with chemotherapy on the basis of study that actually improved overall survival.
This will start
Because most patients were enrolled in China and not in the United States. And then the subset from the United States, with this imbalance for prognostic factors, there was no overall survival benefit, like a subset of 25 patients. And it's interesting how politics will now come into this. You think that overall survival is a hardcore endpoint that's hard to argue with. The treatment improves survival by 40% in the trial. It's a no-brainer. And yet, if it's Chinese patients, then it doesn't count that much for FDA. So we already had several trials that actually were forced by FDA to halt global enrollment can't focus on US enrollments, we need the quota of the US, and I think that's gonna be another challenge of the next couple of years. I think this vote will be very influential how people interpret studies.
This panel yesterday to select providers, physicians and APPs talking about curricular and marginal to train, and yes, and it was a presentation trying to put out a lot of information from different providers, from the providers who are working in academic settings and have access to the clinical trials, and certainly from other areas where access is very limited. Or some providers were like, oh, why I should consider mosatism? I'm okay with rituximab. I mean, again, patients should travel 1 hour to the clinic when they can't be having access. And I was like, I think if this is under representation, I totally understand the limitation, but if we will encourage providers to help patients to reach to the centers that can be represented or enrolled in the clinical trials, we have better representation and better thought, better things. But many providers are saying it, oh, it's worse rituximab. I'm giving this guy who is like 71 5 times already rituximab over past 10 years, and it's okay. This has quality of life, and I'm satisfied. I'm getting paid in my qualities, and it's okay. I was again, I understand the limitation, but this is how we not gonna reach it in for the African American about this. And not that I thought they never gonna help in David. I was like, but I'm very lucky. I'm in the area, I'm hour away from Dana Barbara and LA, and they have lots of for child in my study. It's why I be very subjective on it.
That's a perfect question, sorry. By the way, is that Matt Lauer, or is that you?
Yeah, no, that looks like the daycare.
Yeah, sorry, you're not distracted.
Not yet.
Sorry, I missed your comment. I have a question for you. Has anyone engaged the transfusion medicine free service for any assistance with the big clinics? Public witnesses.
I mean, they often come without us even
Yeah,
asking to they know patients in it and they see the patient. I haven't used any help.
I guess that's what I was curious about.
You can.
Yeah,
Good job.
All right, thanks, everybody.
Mostly, what do they say? These small tubes.
Hold on.